Okay, hi everyone. I'm ready to start if you are. Can you all hear me? Maybe just quickly type yes in the chat, or you can unmute yourselves. Okay, perfect. So yeah, I don't think we will need the 2 full hours today because I only wanted to do a Q&A tutorial today, which I respond to them and then we talk about a few administrative things. And then in the last meta-analysis. Sorry, I was dropping out. Now I'm back. Yeah, so the very last seminar, we will talk about meta-analysis. This is more for your background information because most of you will likely not even need to do meta-analysis, or depending on the number of studies and type of studies that you identify. So you can consider the next 2 seminars as more like a general overview that you could use for other papers or just some general knowledge, but something that might not be as relevant for your systematic reviews. Okay, checking once again that everybody can hear me. My internet connection seems to be a bit shaky today. Okay, perfect. Sorry for that. So I need to share the slides again. Yes. So the first point that I wanted to cover was about the supervision. So I'm really sorry for that. And I wish I could have had more, but as I'm not allowed to take on PhD students myself as a formal supervisor, there was not as much, that much that I could do. So just to give you some background and contextual information, the problem was that Professor Bernighausen was on board for this whole project, and he was initially willing to take on all of you as a formal supervisor. But then, roughly at the same time, I think around 1 or 2 months ago, the Heidelberg Institute warned him that he already reached his maximum number of supervisees and that he wasn't allowed to formally take on more supervisees. So that is the problem that we were facing. First of all, potentially some of you were interested in this PhD position just because of Professor Bernighausen's reputation, and you might have wanted him, or like you might have wanted his name on your CV or like linked to your dissertation. So at first, I can still assure you that if you want Professor Bernighausen to be involved as a co-author, this is still possible, and we will still try to consult him on any open questions that we have. It is more that this formal function he's not able to take any longer. And for this, we have now come up with a solution that there are 3 additional people at the Heidelberg Institute who can act as supervisors because they are formally allowed to take on PhD students. And these are Olaf Horstig, Valerie Louis, and Peter Dambach. You can Google them and look them up on the Institute website. And the idea is that each of you will be assigned to one of them, and they will give you a signature for your immatriculation documents, and then you can finally be immatriculated and finally have the student status again. And this is somewhat independent from who will be your content-wise supervisor. And you might have seen that we have set up our Google Drive document with additional columns where we assigned a formal supervisor to each of you, not yet filled out completely, and then a more direct supervisor who will be involved with the paper and who will be in touch with you on a more regular basis. And then we are also trying to get technical experts for all different diseases. I have already assigned myself to some of your dissertations as a content-wise supervisor or close supervisor. And this is just based on my expertise and what I feel comfortable supervising. And you will see that I've picked the more psychological stuff because this is where I have had more training in as compared to purely medical research. So don't interpret this as any way of me picking favorite students or anything. This is purely based on topical expertise. And it's also working to your advantage because we want you to be supervised by someone who knows something about your topic and knows something about your disease. So according to the same principle, we will then try to assign Valerie and Peter to different topics, and I'm pushing for having this done quite soon. Olaf wanted to meet the students that I have assigned him to. I've emailed you already, and I guess the other two would then also want to schedule meetings with you, like via Skype or in person, whatever suits you. But yeah, I'm really pushing for having this sorted out quickly. It's been a whole mess, and I'm really sorry for this. And none of the three were initially planning on doing this project. So this was kind of given to them once we had realized that Professor Bernighausen is not allowed to take on more PhD students. So they also need some time to figure out their work schedule and everything, but they have all agreed to this, and this is the way forward. It's just a matter of a few more, I hope, days and not weeks to finally sort this out. Are there any questions with regard to this or any concerns? Or has any one of you been in touch with Till directly or Professor Bernighausen directly to talk about this? Is this something that you all feel comfortable with? Okay. I think, yeah, one important point is also that we will assign authorship accordingly, which means that those of you who, or in general, all of you will be first authors, as we had agreed initially. And then the idea is that the technical supervisor or the close supervisor is going to be listed as a senior author. So we might have experts who are involved from time to time, but in a sense, the person you work with most closely is the person who is then going to be given a senior authorship, because we were figuring this is the fairest option for everyone. And as I mentioned before, it doesn't mean that Professor Bernighausen is not going to be co-authored. You would still have his name on your papers. But yeah, he might not act as like a senior author or as like your first contact person. Yeah, and I will keep all of you informed about this, and you can keep looking at our Google Drive sheet. And if there are any concerns or any questions, or you are not happy with the supervisor that you have been assigned with, email me or message me and we can figure something out. But we have really tried to kind of come up with a system now that works in your favor and makes sure that you also are continuously supervised after the seminar comes to an end, because we are finishing the seminar before you have completed most of the stages of your review, and we want to make sure that you are not left alone from now on. But I'm also not able to take on all 10 of you, just because it wouldn't make sense topic wise and also with my time, and that's why we have come up with this new system. Okay, so for the next seminars, the course will work as it did. We will have the two next seminars just myself, probably with all of you. And then this is the strategy outlined here is the way forward after the end of the seminar. So by then you will be split into groups, you will be assigned your specific supervisor, and then you work independently. But we will run the seminar up until the end as it is. So that doesn't change. Any other questions? Okay. Then I think the next thing that would be helpful to do is for each of you to quickly give me and the others an update on where you stand and what stages you have completed and what your next steps are. And before we start, don't look at this as a sort of exam or test. I'm not asking this to judge you. Everybody has different schedules and different other obligations. Some of you are working on the side or have started their medical training and everything. So yeah, this is not meant to compare how far each other is. It's more for myself to know where each of you stand, and then also communicate this to your new supervisors. So maybe we could start. Who wants to start? Quickly giving an overview. Maybe we can just start with the list as it appears in the chat. So maybe Claudia, could you start? Just like giving us a 2-minute recap of what you have done, what your next steps are.
Okay, so right now I'm still at the...
I think are you still...
Can you hear me?
Can you say something again?
Hello? Hello?
I somehow can't hear you, but maybe the others can. Okay, I can't. Yeah, sorry, that was my mistake. So yeah, now with you.
Okay, so I'm still at the screening stage right now, and I also haven't finished my Prospero protocol, so pretty much at the beginning. Yeah.
Okay.
So these are the next step.
Yeah, perfect. Thanks. Then maybe Eliezer.
Yes, so far I've done my Prospero submitting, and I'm waiting for the answer right now. And with my screening, I'm like nearly done. I'm in the last stage of it and trying to decide for the maybe ones, going through their reference lists. And yeah, that's it.
Great, yeah. Has any of those who have submitted to Prospero already received a response? Probably not. Yeah, it probably take.
For me, they told me specifically it's going to take around 2 to 3 weeks right now.
Okay, okay. So yeah, all of you, I guess, who have submitted are still waiting. Okay, great, thanks. Then Eva, do you want to continue?
Mm-hmm. So I'm also still at the screening stage, but I also submitted my protocol, but yeah, no answer yet.
Okay, perfect, yeah. And Felix? Did you unmute yourself, Felix?
So
okay.
do you hear me now?
Yeah.
Okay, perfect. Sorry. I'm almost finished with the screening, so I'm actually doing the maybes. I'm fighting with the fact that I'm since I have this alcohol abuse topic, that I have quite a lot of included studies, 250 out of 14,000 hits. So yeah, that's I just watched the last year's last meeting yesterday. So we discussed this in the end. So maybe I'll talk to you a bit, Janina, how I can further approach this, because this topic it was clear. I guess the person who's doing hypertension has also quite a lot of hits, because there's just a lot of work on there. Maybe we can check out how we can focus more, since
200 is too much, so Yeah, that's a good point. I mean,
I
yeah.
mean, we did it scientifically correct. Maybe we can, I don't know, further distinguish some timeline or whatever. Yeah, we can
Yeah.
discuss in private.
Yeah, no, definitely. I don't think this is a sign of you having made any mistakes. It's just that it's probably topics that are highly researched and there's a lot of recent work ongoing. But yeah, we can discuss this on an individual one-on-one basis. But one idea would be to kind of constrain to the last 3 years or to low-income countries only, or
Yeah, I was thinking about something like
types,
that.
or
Yeah. Okay.
But yeah, email me individually and we can sort this out. But yeah, whoever feels at this stage that you might have ended up with too many studies so that it doesn't seem manageable, the next step would be to put another constraint on eligibility, and by this reducing the number of hits. And then, yeah, we can sort this out individually.
Okay, great.
Cool, thanks. I think then we have Hannah.
Okay, can you hear me?
Yes.
I'm still screening and I'm half through. I have still 13,000 left, so it's still a lot to do. And the next few days I will submit my Prospero.
Okay, sounds great. Yeah. And I think the last one we have is Veronica.
Okay, do you hear me?
Yes.
Yeah, okay. I almost finished the screening process. Yeah, next I'm going through the maybes. And I finished the Prospero protocol, but I did not submit it yet.
Perfect, yeah. And great for all of you to have finished the screening or still going through the screening. I know it's like a super annoying, time-consuming phase. And from now on, it will get more exciting, I can promise. But that's usually the phase that I dislike the most. So yeah. Okay, but that sounds great. And yeah, but still, I mean, obviously you are all still at earlier stages of the review. So it's really important that we have a solution where everybody is supervised throughout the later stages as well, once the seminar has finished. Okay, so the remaining time I would just use to go through your questions and providing responses. And if any of you have other questions in mind or additions to my responses here or further clarification questions, feel free to interrupt me at any point in time. Yeah, so one of the first questions was that you put the inclusion criteria, many of you did, to publications within the last 5 years. And then you would often come across full text once you look at the PDF versions of the full text, which are using data from before 2016. So for example, you could have a study that was implemented between 2009 and 2014. So yeah, if you think about this as data from 2016 onwards, this would be a problem. But you have put the restriction as the publication date, so this is what counts. And we would expect that the data is not super up to date until 2016, because there are always delays in publication. So it's naturally expected that your data would be from a bit prior to the publication date anyways. So you can disregard this fact and just stick with the publication date. This is what you defined and all else is fine. Does that make sense? Let me know if not, yeah. Okay, then next question was, many of you had these similar questions. that there are often many cost-effectiveness studies, which means that studies that compare, for example, usual care to intensive care. Then the question is whether these should be included. So in general, cost-effectiveness is, or costs saved of a certain intervention, is not what we are interested in. But often, in order to reach an estimate of cost effectiveness or an estimate of how many costs were saved with a certain treatment, it is a medium step of these analyses to first define the costs of an illness, the direct costs or the indirect costs, and then define the costs of the treatment, and then deduct the treatment costs from the illness costs, and then you have kind of the costs saved. So if these intermediate steps of the analysis are reported in actual numbers, so if you find in these cost effectiveness papers some information on the direct or indirect or both costs of a disease, then you should include the study. So I think at the screening stage, I would do the studies, then look through them. You would find this, I guess, at the beginning of the results section, possibly, or at the end of the method section, maybe not in the abstract and the conclusion, but this is where the information should appear. And if this information is not reported, then you can exclude the study. Okay. Yeah. If you have any concerns with this, let me know. I think we have a very similar question again later. Then another question was that there were also studies that look at prevention of a disease and then the costs saved through this. This is similar to what we had here. So yeah, you can look at the costs saved as the costs of the disease minus the costs of the prevention efforts or the intervention efforts. If the disaggregated estimates are shown or reported other than the total sum, then you would use this information. Okay, any questions with regards to that? Okay. Then I got this question from some of you, what are the next steps once the RYAN screening is completed? So the idea is that then you start with the full text screening and with the data extraction. I think the first step would be that for the list of references that are included, you only have abstracts and titles in RYAN. So what you do is you look at the full text PDFs, you download them from Google Scholar or another database, and then you save them in like a new folder. And then you start reading through the full text. For each of them, you critically assess whether they really meet your inclusion criteria. And if they do, you can start with data extraction. But you expect that from this list that you now have marked as included and maybes, you will still likely exclude some after full text assessments. So yeah, this is related to this. For all the articles marked with maybe, I would say the first important step is that you read through the full text and you see whether it's then easy to make a judgment based on the full text. Most often it becomes clear. Abstracts are short and a bit vague, but usually after reading the full text, it's more clear whether the study is eligible or not. If you are still unsure, and this applies to all included or excluded studies, you can share the article information with me, or if you have a second screener for your titles and abstracts, you can share the information with that person or your new supervisor or whoever, and ask for a second opinion. And this is fine, and this is what you can report in your method section even. You would write disagreements or uncertainties were solved by consulting a second and third author. So yeah, you can kind of make a list of all the articles that you're unsure about and double check with me or another co-author to decide.
And I would almost, Janina Till here, high excellent session, and I would almost make a slight adjustment to what you're proposing to save you from doing too much work, but also because peer-to-peer is a good idea and nice and fun. And then we have an arbiter. So I would say, why don't we, for the maybes, and possibly there will be very few, but it's always another peer. And if the peers disagree, right? So in a sense, it is a disagreement that you have with yourself. Now, a peer might lead to another situation because it's only two people. So you don't have a majority. One says in, the other one says out. These will be rare instances, but I think in describing in the method section, it's just a few sentences, but it looks right and rigorous to say, we had a second person make that judgment. Facto, the judgment is one that we make in the maybe cases when it's unclear. There's no need to make such a judgment when it's very clear, of course. And then these two people disagree, you and I and Sebastian and advisors come in as arbiters between the two potentially diverging opinions.
That sounds great, yeah. Do all of you, just as a double check, do all of you have partnered with some of the other doctoral students for the screening? Or are some of you still alone so far? Anyone who hasn't, okay, so Eliezer hasn't teamed up with someone, and neither has Claudia, I think. So yeah, maybe you guys could, based on this, decide to team up, also work at some point on the double screening of the 10% of the Ryan hits, which will improve the of your screening and eligibility assessment. And then for all the maybes that you remain unsure, you can then discuss amongst yourselves and then consult me, Till, or Sebastian if you disagree. Okay.
I like this idea that you have introduced, Janina, and all the peer-to-peer support. And one, it's just a proposal, but if all of you agree, I would say in this type of publication, there's little loss if more authors are on a paper. And the peers should then also be co-authors. That is, you more papers out of this effort than you would if you just did your two papers. So you will, on average, I would assume, also be on two other papers where you serve as a peer.
Maybe I can ask a question regarding this topic. I agreed with Marie to do this, so she proposed the 10%. Is another idea, but maybe it's not used scientifically, if she would check my positive results, or because we discussed how should I distinguish these 10%, should I just go through randomly her Ryan list and do checks as far as I reach up to 10%, or should I do the maybe? So is there some common way how you approach this?
So
if you do the 10%, I would do random. Otherwise, it could be a manipulated 10%, right? So we have to leave it to chance so that we are not under suspicion that we manipulate the 10%.
For example, if you just look at studies that you have included, it could be that you are particularly strict to include studies, and then your second reviewer might disagree and not exclude some of them, so you would miss all of these.
Yeah. Yes.
So random is the
so
way.
The 10% has to be random, but then the peer, I think, serves in several functions, right? And one of the function is the maybe disagreement with yourself elimination function. another role would be the criteria double checking. Yeah, but they are separate functions, of course.
Yeah. Great. Any other questions with regards to that? Otherwise, I can move on to the next. Yeah. So then we had more questions on how exactly the data extraction works. So I think the first step would be to come up with a data extraction sheet or form. I have usually used just an Excel file for this. And then you use different categories. The example I copied here is a totally different review question, so yours will look differently. But the information that you need to include is usually the study reference, year of publication, the country of the study design, the sample size, and then the different outcome measures. So you would definitely separate into direct costs and indirect costs, and then extract all the information on this. And what I usually do, but there are different ways of doing it, is that at the first go, I just copy paste information from the PDF into the relevant Excel file, columns and cells. And then I have, with this Excel file, I have one document that stores more detailed information. And based on this, I then create a clean, smaller table for the final manuscript. But you can use other strategies if this works for you. And I would suggest, because this is an important part, that you also share your data extraction form with me, and ideally also Till and Sebastian and the other supervisors before you start the extraction, so that we can also give some feedback. And then it's also usually a good strategy to try it out with 1 or 2 or 3 studies and see where it doesn't work, or whether there's something that you have missed, whether there's something that you need to disaggregate further, and then you can still adapt it before you extract all the other studies.
And great, Janina, can I also make a comment building on what you have said? So a common mnemonic for extraction categories is PCOS, population, intervention, comparator, counterfactual, the outcomes, and the study design. So PCOS, P-I-C-O-S, is a nice mnemonic as a starting point, what to extract. And then, of course, date, community, countries, and authors, right? So there are some setting and publication demographics, but very important that I think Janina and I and Sebastian and others, Olaf, look at and discuss with you, because it is more work if you have to revisit, right? If you have to go back to all the articles again, because after we look at the results, we say, oh, there's another 5 factors that we should have knowledge about. You haven't extracted education. And then you need to revisit, right, the 25 articles and need to find again in each and every one. There is a loss here, because it takes some time to get to the tables where they are, and then it's relatively quick to extract the information from the tables. So better to have this already pre-discussed and confirmed. And I'm almost wondering, Janina, if we couldn't devote the next session to it also, that we go one by one, 5 to 10 minutes each, and briefly go through all the extraction criteria for all the studies. It is a joint learning exercise, but it gives us an opportunity to sort of publicly vet that we don't waste time having to go back to the studies and extract in different rounds rather than.
Yeah, I like that idea. If if you agree that you can come up with a data extraction form within the next 2 weeks, I think it's a feasible time frame. That would be a perfect use of the seminar.
And you can start with the ones, so be inspired by this example from Janina. Look at the PICOS, P-I-C-O-S framework and memory device, and then think about clearly authors, publication year, journal, country, study year, years, right? The time of the study, the place of the study, the community. Possibly if it is about health systems components, we also want the health systems context. Is it primary care versus community-based versus tertiary care? So it'll very much depend, right? It's a domain decision. There is no universally true or false set of categories. It'll depend on your question and the literature that is available.
Great, yeah. And maybe one idea, if you are still unsure about how to design your data extraction form, you can also look at systematic reviews on the economic burden of a certain disease and check their table of included studies and see what information they report usually. Yeah, but based on all of this, it should be quite straightforward. Great. Then I move on to the next question. That was about the inclusion criteria and age limits. So some of you will only focus on adult patients or on adults in your systematic reviews. Then it's fine to say you focus on individuals aged 18 years and older. It's not necessary, I would say, to also indicate an upper age limit. I wouldn't put this as a restriction. Or do you think for certain diseases still it would make sense to define an upper age limit?
I mean, with regard to do we have indicate upper age limit? Yeah, so I could imagine, right? So sometimes, so typically I would, as a default, I would use no age limit. And this is in regards to upper or lower bound, both, right? So as a default, do not apply any age restriction criteria. Now, there will be exceptions, or there could be exceptions. For instance, if you're really interested in adolescent health and there are certain interventions or certain conditions that are very differently meaningful in adolescents versus in older adults, then you might want to constrain your relevant articles to the age groups 10 to 20, because people under age 10 are not adolescents and people over age 20 or 19 are not adolescents. So if you have an interest where the fundamental interest, your definition almost includes an age limit, then you have to apply it. But this would be exceptional, right? If you're very interested in adolescent health and you're really only interested, and your title is, right? Your envision title is health promotion interventions, the economic burden amongst adolescents, then we would, of course, apply a age limit. But otherwise, I would not apply any age inclusion or exclusion criteria.
Yeah. Yeah, so maybe this would be interesting for Claudia and Felix, who have more than 200 included studies so far. So one way to refine the scope and make it more narrow would be to think about an age group that your disease might be specifically relevant for and try to reduce the number of studies for this age group.
Can I ask Claudia and Felix what your diseases and conditions and topics are? I jog my memory.
Mine is alcohol abuse. So I included studies from 2009 onwards because I had 25,000 hits in total first, and then Janina and me agreed on putting this time frame. But of course, there is a lot of data out there. I think it would be quite interesting. I mean, since I just have to look through all the studies, maybe to go into certain regions regarding, for example, Christian or Islamic, or according to income, because there are quite interesting differences. I think, yeah, the main age group would be 20 to 50 approximately, when I'm guessing now from what I've looked through. So yeah, one has to look into it a bit more detailed, I guess.
And how many relevant records have you identified that you think you need to extract information from? 200 something?
Yeah, well, I went through I have 200 and something green studies now. The thing is that I of course only read the abstract, and I was rather putting them on green in the maybe case than rather excluding them, because I think if I read into them, I can exclude all the time if I excluded. I mean, I went strictly with the inclusion criteria, but of course, sometimes the abstract doesn't really tell you, does it really focus on some costs, or does it really look into economics and costs, or is it more just a medical approach? So of course you have quite topics which go together, like liver cirrhosis, and then is liver cirrhosis cost directly always related with alcohol? No, it can be all kinds of things. Yeah, just to give you an idea how I looked into the studies.
Yeah, so maybe my proposal, this is laterally related to this question, but maybe also important for others. I would, as a next step, do the full text, sort of a very diagonal reading. So your question, right, is economically relevant information included. I would now do a diagonal reading of the 200 something articles in a day or two, just to screen the full text, not read in detail and not extract yet, but do a full text review and do it by just looking into the text. Do I find exactly your question, right? Do I find relevant outcome information? And
yeah, I think that would be my approach, because I guess, I mean, I can't really say, but judging on what my experience is, since I just looked through everything, I would say that in the end there will be maybe, I would guess 50 to 80 studies which have really content which is super relevant. And then the question is to limit it out, like as we discussed before. I think the same will apply to, I think it's Claudia, whoever has hypertension. I fully agree. I would go the same approach as you proposed.
Right, and that's the first step. So maybe the screening that is based on the full text screening, but diagonally reading, you can be, in a sense, once an article is in, you give up, right? That's it. Once, or as long as you think it is out because you haven't found any relevant information in there, you might be doubtful and might want to dig deeper. But let's try to do this quickly, because then maybe you can discuss with Janina and I think Janina's and your idea to constrain further and rather do more than one article potentially, especially since alcohol consumption is also so affected in its economic impact by context and culture. so cultural context, but also political context and religious context, right? You already raised it. I would find it very meaningful to do a review in Sub-Saharan Africa and a review in East Asia, for instance. So to constrain yourself to world regions may be another good way to make this realistic. Every article will take several hours if you want to diligently extract the information, right? You need to make sure that you get it right. There will be quantitative information. So 200 times 3 hours are 600 hours, and it becomes unwieldy. So we should get it down to a number of articles, and it should still be meaningful. And especially for your topic, alcohol consumption, I see that it is meaningful to use a geographic subset, such as Sub-Saharan Africa or Eastern Europe.
Okay, great. Then, yeah, I'll be in touch with you both then.
Great. And maybe this next stage will already get you down to a more manageable number.
And then the other person who had so many hits was Claudia, right?
Yeah, right. So I have pneumonia as a topic, but also I didn't divide it into community acquired or hospital acquired pneumonia. And there are lots of studies that included patients with comorbidities like COPD or HIV. So I think I can divide it further into these conditions probably. I have around 180 included right now.
Yeah, that's great. And especially community versus hospital acquired seems a very powerful distinction. Will actually increase the, I think, because we view community acquired pneumonia as very different, right? For good reasons from hospital
right.
or nosocomial. So I would like that. Nosocomial one and then the community acquired one, that's closer to where we work, right? In primary care, in the community, and then you already have 2 very good papers. So maybe that replaces one of the other 2 papers that you thought about.
Okay, great. Perfect.
And then regarding the comorbidities, maybe once you do a full text screening confirmation and get a little bit an overview, maybe also good to discuss with Janina and I would ex ante not exclude comorbidity focused pneumonia. I could imagine in the community base, there are few comorbidities, right? That's just the general population, and it'll be an older and a younger population, children and adults. So let's see what we have in the hospitalized one. Maybe it is amongst patients who have had a bone marrow transplant, right? Also, there may be very specific patient groups that are predefined by the reason that brought them to the hospital, and that may diabetes treatment, a surgery, right? So I could imagine that we run into this comorbidity issue because in the hospital wards, doctors work in specific wards and they will do studies on their patients. They're interested in pneumonia as a comorbidity, and it is amongst already a pre-selected group of patients. Mm-hmm. Because of that, I would not exclude ex ante by comorbidity and simply reflect the evidence by particular patient group, HIV patient versus diabetes versus kidney failure.
Okay.
But it would be an option. If it's still too large and unwieldy, we could say, look, it's in people who are in the hospital because they are on dialysis.
Yeah, for now I just included everything I found. So yeah, but there are some really specific groups included.
And that's okay, right? So the systematic review, that's a finding. You would reflect the evidence across different patient groups. That makes your systematic review rich to some extent.
Okay.
Yeah. And it's great what you're all doing, which is what we discussed in the screening stage session, that you are at this stage you are still over inclusive, like rather be safe than sorry. So you probably in your list you still have more studies than what you will finally end up with, but that's exactly how it should be. So this is all correct. Great. Okay. Then moving on to the next study, next question. Again, similar to what we had before, do we include studies that contain prevention costs? It's great to have you here, Till. I would say yes, if they report disaggregated cost estimates for the disease costs. And then the cost saved or the cost effectiveness is just the final outcome metric that they report. You would still find relevant information in this type of studies. I would, yeah, that would be my answer. Do you agree, Till?
Yeah, it depends a little bit on the question, right? So we may be interested. So yeah, just thinking this through, and I think it's a case-by-case decision. So the economic burden, we sort of envision there is a disease and now that burdens you in other ways than just your health. And then that's the side of the patient, right? And that's actually the main motivation that we initially had for this work stream when we discovered that this literature doesn't exist, which was more thinking about what are the economic outcomes that people who have a condition and who receive a treatment suffer or benefit from, right? So the treatment hopefully would counteract economic burdens of diseases. And that's very much a patient perspective. Now, as many of you have looked into the literature, I think we have often a little diet where one paper is on the health systems expenditures, that's the supply side or the system side, and the other one is more on the patient side or the demand side or need side, if you will, which is our original motivation. On the health system side, then we're interested in the whatever we call it, right? The costs. So this morning we discussed the breast cancer screening paper, and that's a preventive intervention, right? So there the prevention costs from the systemic perspective are the main interesting ones. You know what I mean, right? So it'll depend on our focus, I guess.
Yeah.
Sorry, that wasn't very clear, but I'm just thinking out aloud. So Franziska, right? So in your case, the cost of different screening programs, sorry, not breast cancer, but liver cell carcinoma, that's a prevention intervention, and we're interested, or an early detection intervention, secondary prevention costs, and that would be our main interest here. So whoever asked that question, what did you have in mind?
I asked the question. I have the topic economic burden of periodontitis, and it's about whether there are costs, which are caused by periodontitis. So the therapy, but there are also studies, which contain the prevention costs, like prophylaxis, like how a patient can clean his teeth. So I think in my topic, I don't include the prevention. So yeah.
Right, and I think that's a good decision. I also think that independently, it would be very interesting to learn about the costs of the prevention in intervention. So our institute is typically in the business of designing and evaluating health interventions for populations, and they're often preventive or testing or early detection interventions. And thus we're very interested in how much these cost. And things that we can do as preventive interventions are a mainstay of public health, population medicine. So it's really sort of intrinsically interesting to us, but I agree it's a separate topic. So I wouldn't mix them with the economic burden of periodontitis. And if you still need a paper later, then you could do a systematic review of the costs of different approaches to prevent periodontitis. That would be very interesting, but it's a separate paper, a separate study.
Okay, thank you.
Yeah. Did anyone else have an example, or because we had, I think, 3 questions that were similar to that one. Does anyone else want to discuss this with an example from their review? If not, this is probably also something that we can discuss as we move forward. This was very helpful already. And yeah, then if you are unsure about certain studies, this would be the case for the peer review, the peer assessment first, and then the third author decision or arbitration.
Yeah. And I mean, your logic is also very sound in many cases, right? There's disease cause minus prevention. So let's look at it as a case-by-case basis. I think, Veronica, in your example, it's clear that you can legitimately exclude the prevention papers. And if you need a third paper or want to do another one, that would be quite interesting, but I wouldn't mix it up with your current economic burden of periodontitis paper. And that will be the case in, I think, many cases, but happy to be a sparring partner, and Janina, of course, as well, in making that decision with you.
Great, yeah. Okay, next question. Should indirect costs also be represented as concrete costs, which means in numbers or in dollars, or would we also mention disability adjusted life years? At this stage, I would extract data and information on any measure of costs, either monetary estimates or estimates in the form of DALYs. And then this is something you can discuss in the discussion section or consider in more detail once you decide whether to do a meta-analysis. At this stage, I would just descriptively extract the information from the paper as it stands, and then decide later which outcome measures you can summarize in one measure and which ones are too different to be reported as the same average effect size. And many cost effectiveness or many economic burden papers that I have looked at so far often report both. They would report monetary estimates and then also convert these into DALYs, for example, but yeah, this will depend on the specific study, I think.
Yeah, and just one thought, and Janina, good to think about it jointly. And I think it's maybe also a case by case situation. So I make a very strong distinction between two types of studies, but then there are also mixed or integrated types. But I would be more interested in the empirical studies, the ones that have really measured something in this life. And DALYs, we very, very rarely measure, right? They're typically predicted or simulated from a simulation model. And I think we here are more interested in what really has been measured. And now there will be a few studies that are reporting as primary studies the empirical estimates of a cost, and they are decision analytical models of cost utility, DALY eliminated per dollar invested, and they also report for the first time an empirical finding. So these studies should be in. And then there are some studies that are empirical, and as an afterthought, they give us a DALY estimate, as you say, Janina. I would treat the simulation models that do not report also empirical data as primary sources, either separately, and they could be a separate, or I would throw them out. You know what I mean? So we have studies that go out, that sample populations, and that find out about the causal effect of liver carcinoma on earnings. And then there are studies that quantify the DALY burdens of liver cell carcinoma by taking some data that describes the prevalence of liver cell carcinoma, another data source that describes the disability rates in liver carcinoma patients, and yet another data source from another country that describes survival with liver cell carcinoma. And then they throw it together in a model and give us the DALYs caused by liver cell carcinoma. And then they monetize it. And then they say, oh, we know that a DALY is 3 times per capita income. That's the monetary value of a DALY. And then someone else says, and oh, we've done a macroeconomic study and we've derived the new estimate of a DALY value, and it's 4.2, right? As the Summers Lancet Commission did. And then WHO says, but we're also thinking from a human capital approach, it's 1 times per capita income, right? So these are ways to monetize DALYs, and they're not very meaningful. And they are not really what we're interested in. We are interested, I think, in the empirical literature. If we are also interested in the DALY-derived cost or burden, then in many cases, I think they are, that would warrant a separate review, right? What do the decision analytical or the simulation model insights give us in summary, rather than what we have really measured in our empirical work?
Okay, so we could almost make this an inclusion restriction for now, that
yes,
the study we include needs to report on empirical data.
Right, and I would even qualify it a little bit more, and maybe that will also solve some of the problems where there are too many articles, because they're really of a different type. And if we are cynic, we could say they're made up numbers. I'm not such a cynic. There is a place for simulation and prediction, and it's powerful, and we do that in our own work, but it's a very different exercise. And I think for the economic burden and the cost side, we do not want assumptions. We want truth and facts and hard measured data. And I would go even a little bit further as an inclusion, or more specific as an exclusion criteria. It is not the primary source of empirical data. So the only exception to include a modeling study in the empirical review, and we can leave aside the option maybe for some of you to do a separate review on the simulation models, right? That may on occasion be meaningful. What do the decision analytical models show or the simulation models show? But that's a very different source of data and insights. Let's leave that aside. For the empirical systematic review of the empirical evidence, I would include those rare modeling studies that report for the first time empirical data, and they do exist, but especially because we are interested in costs, right? So there are some decision analytical models that use as a data source for their cost estimate empirical work that is only and for the first time reported in this decision analytical article. If, which is much more common, there is an empirical study that quantifies the costs, and then someone goes ahead and uses these costs as an input into a decision analytical model, that decision analytical model article should be out, and the primary article, empirically reporting the costs, should be in. Hello? Hello, hello, I cannot hear. Is that clear? Or do you have questions? Yeah, Felix, I see that you say good to know, also in my case. Yeah, so this might relieve you of 15 articles or maybe even 50.
Great, yeah. Anyone have questions on this? I think that was really an important point. Okay, then the next question was on, again, cost effectiveness studies about different special therapies or interventions. Let me share this. This is similar to what we discussed before. In general, we are not interested in, for this kind of review, we are not interested in the cost effectiveness of a certain type of intervention or therapy. But if these studies, prior to assessing the cost effectiveness of a therapy, if at a first stage they are determining the direct and indirect costs of the given disease, then this is information. And if this is primary data information, then this is something that you would extract and that is relevant.
Yeah, and the primary data, so a very typical cost effectiveness study takes from different communities and different time periods, cost effectiveness estimates, and often the effectiveness estimates are from trials, and the cost estimates are observationally measured or even assumed. I would hear the primary empirical evidence definition, I would take a very broad view that's sort of counteracting a little bit, throw all these cost effectiveness models out, etc. Because sometimes what cost effectiveness studies do, and I would include that information, is that they use an expert panel. And they sit people down and they elicit from those people, often physicians or hospital administrators, cost estimates or maybe impact on education estimates. I mean, this is a border case, but include that as empirical evidence because they've done an empirical exercise. They've just used weak means of getting there, right? They've interviewed experts, but and I could go either way, exclude or include, but I would very briefly screen these articles and see if they report for the first time, i.e. without a reference, an empirical estimate of some type of the direct and indirect costs, exactly as Janina says. If they report, which is much more common, will not for the first time report these costs, but take them from the extant literature and that is for your reference, then the reference has to be included, but not the article
Not the, yeah.
effectiveness study.
Yeah, that makes sense. Okay, great. Then I think next question. This was more a technical, logistical question. Does it make sense after going through all the study screening and extraction to then search the bibliography of studies? Or do we first this and then do the extraction and the risk of bias assessment? So my recommendation is, because what we defined is that we search through the 2 databases, Web of Science, PubMed, and then I think Google Scholar is also what we decided on, and that we then also look through all included studies, the reference lists, whether there are other studies that seem to be eligible. So this is what I would do before starting with the data extraction, so that you have a final list of included studies once you start the extraction and the risk of bias. And this is also a separate piece of information that you enter in your Prisma chart. If you remember, the first stage was composed of studies identified through searching bibliographic databases, and then there was another part which was studies identified through other sources. And this is where you would list what you identify through a hand search. So you would list the number that you identify, for example, through searching the bibliography there, and then you only start the extraction stage and the risk of bias assessment stage afterwards. Okay. This seems to be clear. And just to, so that all of you remember, it makes sense now, once you have come up with your list of eligible studies according to the title and abstract screening, you can already input these counts in your Prisma flowchart now. And then the next stage, the number of studies you include or exclude based on the full text assessment also is information that needs to go into the Prisma chart. So yeah, just to like remind you of documenting all of these stages and the counts and numbers thoroughly so that you can fill out the Prisma chart. Then the next point was regarding the risk of bias assessment and whether we then don't include studies because they have been flagged for a high risk of bias. So the idea is that our systematic review would still list all the studies that are eligible according to our eligibility criteria. Even those with a high risk of bias would appear in our list of included studies in the table, but then they would be assigned a different bias rating or quality rating as compared to the other studies. So you still count them, you still include them, you don't exclude and ignore them because they have a high risk of bias. But if, for example, if you were to run a meta-analysis at some stage, it might make sense to include the high risk of bias studies there, or you could run a robustness analysis, excluding them afterwards and checking whether your average effect size changes. But as of now, you include them, they don't get excluded just because they have a high risk of bias. You can consider it as part of the research transparency of your systematic review that all identified studies are reported. Okay. Then we had the next question with regards to indirect costs. There are several studies reporting on disability ratings, unemployment, homelessness, and you say all of these can be considered as human capital losses, which I agree with. And then they often are reported without associated costs. So you are asking how we can deal with this and whether you can calculate and kind of attach numeric cost estimates to these outcomes. So yeah, you rightly identify them as potential indirect costs. Homelessness, I'm not quite sure about. I think I would exclude homelessness, but definitely unemployment is an important indirect cost. No, potentially homelessness we can also include. And what I would suggest to do is that you report them as outcome measures. Usually a systematic review does not entail making any new data estimates or producing new data that is not there in the primary included studies. So if they are not costs attached, I don't think this is something that you would be doing in a systematic review to then provide cost estimates. We would just report them in your table of included studies as outcomes, but then discuss or mention that they have not provided numeric cost estimates. And I'm not sure about homelessness. What would you say, Till, or the others?
Yeah, well, I think it's, if you are super strict, I mean, you would have to include it. I mean, I have a lot of studies which are quite the same, which are, of course, unemployment and homelessness, even I think breaking up of couples is included because of alcohol abuse. So of course this all then has an effect on maybe how productive people are, or if they lose their job then because of the homelessness. But I don't know, it's then it gets like super complicated, and I think that's not the aim of the systematic review. As you said, we should make any estimations from data which is included in the current studies.
Yeah.
Yeah, I would see it a little bit differently maybe, and I think we have discussed that before. I think it depends on a case-by-case basis, but our original motivation, actually what I think is the, let's say, more cutting-edge contribution to the literature, is the impact of a disease and the impact of a treatment on things that aren't health, but social and economic. And this will be, and what matters here is very different by disease, but I like your example, Felix, alcohol breaking up marriages. Now, I'm really certain there's a systematic review on the topic, but what a powerful topic it is, right? And I would almost focus more on those outcomes than on the costs. And I think for a few of you, we have now a diet of papers where one is the cost side, which is the cost to the system and hopefully the cost to the patient. And one perspective on the cost to the patient is, of course, loss of employment, loss of income. But a more powerful paper would be the evidence on the causal effect of alcohol overconsumption, alcohol consumption, alcohol abuse on marriage. That alone, I would find a very, very powerful topic for a systematic review. What do we know? And you know what I mean? And I would almost see an opportunity here to carve out an additional systematic review. So if you have such a topic, the cost side is of interest to an audience who are actually the modelers and who are the ministers of finance, maybe. The audience interested in the effect of alcohol abuse on marital survival, marriage survival, is probably and a very different one.
Mm. Or also the effect of homelessness or of alcohol use on homelessness would also be an interesting one.
Yeah, employment, homelessness.
Mm.
So for many of you, I think if you're already now in a certain road and a channel don't change, and some of you have decided, I know, or have a plan to do one article, which is the cost side, and that's the systems cost, the public sector expenditures and the private expenditures for a treatment, and also for a disease maybe. But the other topic is really the one that is even more exciting. So if you can, at this point, if you haven't, but you can include that topic, I would like to encourage you to make this your second paper or your first paper, which is the impact. What do we know? What does the literature tell us about the impact of a disease and a treatment on education, employment, homelessness, social deprivation, survival of marriages, number of children, right? On those social and economic outcomes that we care deeply about. We want our children to be well educated. We want a population not to be homeless and live on the streets. And if alcohol is a major cause of that, and no one has summarized the evidence on it, we should be the first ones to do it.
Yeah.
Okay,
So
good to know. Well, oh, sorry.
Go ahead, Felix.
Yeah, I mean, I guess half of the group is not listening anymore. Yeah, the thing is, I included all these studies because I just thought, I guess it's the same for other people, that this actually is an economic factor. So maybe the suggestion is, as you said, to really focus on one review which takes studies which are super straightforward, saying, okay, we look at direct costs, indirect costs, and have, so to speak, numbers. And then we have these kind of secondary studies which focus on another topic, on a smaller maybe.
Yeah.
There will be fewer studies, but they should also have numbers, right? So they should be quantitative. And if you can do it, so Claudia, you're texting, but wouldn't this require a different string? So let's have a look, right? And I think for those of you who are advanced, and let's stick to the cost, but those of you who are maybe not that advanced or who have a search algorithm that we would have strong faith in it, including the economic outcomes, and by that I mean employment and homelessness, yeah, and even the social outcomes. And by that I would mean marriage and number of children and participation in community events, right? So those things are really the more cutting edge ones. And it would be great if we could include them for many, but it's not a requirement. Right? So if you're now already along a path of having done work and it's all about the cost side, and that's absolutely, and they will be cited and used and are very valuable contributions. They're just not as cutting edge or unexpected, right? So people expect those data, but still in the healthcare sector, people are less accustomed to thinking about health as a determinant of education, of employment, of homelessness, and to do that by disease is quite powerful.
Yeah. Maybe to add to this, because we have briefly discussed this in our last seminar. So one possible way forward for most of you would be to do a first systematic review on the direct and indirect costs, very straightforward
Yes.
economic burden systematic review. This is what most of your search strings are defined for at this stage.
Yes.
So we had discussed this with Marie, I think, with regards to child abuse. So she will do one systematic review now on the economic burden of child abuse. And then it would be a nice idea for a second paper to pick one economic outcome that you are interested in. Say, for example, Felix, you would pick homelessness, or in Marie's case, she has picked education. How does child abuse affect educational outcomes?
Yes.
And then you do a review on just the link between these two variables, and then between the disease and the one outcome that you've picked. And I think then it also becomes important to consider the study designs, which will be totally different to the cost of illness studies. And for this, we might want to put restrictions on having a quasi-experimental or experimental study design. And then use the different risk of bias assessment tools that we have discussed in the tutorial in December. So it will be a different kind of review, both in terms of the research question and also in terms of the study designs that we include. And I think for this, it might be necessary to redefine the search string for your second paper.
Yeah, that sounds perfect, Janina.
And
exactly.
I think this is especially where also experimental studies and RCT studies can come in. So just thinking at the alcohol question, we would then also be interested in trials that are trying to prevent alcoholism and have the rate of homelessness as an outcome.
Yeah, my hunch would be that we'll find a quick, rich literature. We find a few articles that are experiments and maybe even fewer that are good quasi-experiments. But my hunch is there will be many, let's call them conditional association studies, right? So analyses where someone has a data set and the outcome is employment and one predictor is alcohol. So I think it would be worthwhile taking them into such a review because there are existing evidence on that relationship, even though they're causally relatively strong, but they attempt to be causal. That's why they're controlling for confounders in a multiple regression, right? There will be many articles, topics in that topic. And then the conclusion is the evidence is there, it's vast, but it's very weak, right? There are 50 articles that associate homelessness with alcohol abuse, but nothing experimental, nothing quasi-experimental. And then that's actually very powerful as a finding, right? There's a strong hypothesis generating level of evidence on a causal relationship, but nothing that proves a causal relationship.
Yeah.
But it's maybe for a few of you, so there are a few that are already doing that. And I like your idea, Janina, if you do it for one outcome, because it'll be too confusing for people to throw into the same article, homelessness and marital maybe. So again, it'll depend. It could be a little cluster of outcomes and maybe unemployment, homelessness, and marriage actually cluster quite nicely. But it could also be just the causal impact on education, as in the child case, which I find really interesting. And typically, the narrower, the better. So if you have one outcome, educational attainment as an economic outcome, and we for the first time show the literature on that relationship, that's very powerful and easy to sell to reviewers, I would think.
Yeah. Okay, yeah, but it doesn't mean that you can't continue with what you have set up so far. This is something that we can also discuss for a potential second paper once you have finished the cost of illness review.
Yes, and you haven't, so do the first papers that you have worked on, and no need to do a second paper that requires an additional search. If you have 2 papers in the initial search, you can totally continue on that path, and that's good and very valuable work. And for those who don't have a second paper, or where maybe the second paper isn't so interesting or so, and you have more appetite, you would need to do a different search in any case, right? So you haven't wasted any time if you're interested in the second type of topic, causal effect on education, including sort of conditional association studies, but you would in any case have to do a different search. So you can do it later if of interest and important, but you can also not do it. Both are good.
Great, yeah. Okay, then I move to the next question. If you are not able to find an abstract or the full text for an identified title, what do you do? I think the first step would be to try email the authors. If you have the author's name and you find contact information for them, you can email them directly and ask them for the full text. If this is not successful, then yeah, I think you have to drop the record if you can't find it anywhere else. Right. That was again with regards to the age restriction. We have discussed this before. Generally, I would not apply an age restriction, yeah, unless it makes sense for a disease-specific context. And then the last question was, is there an easy way to open the full text via Ryan or any bibliographic software? And I think there's not via Ryan at least. So what I usually do is just copy paste the reference into Google Scholar and then try and access the paper, the full text there. Or often you are provided with the DOI hyperlink in Ryan, so you can just click on the hyperlink and access the paper. If there are any access restrictions for you because you have an affiliation with a German university that has restricted some Elsevier journals, you can also check with me first, because I might have access via my UK account. Or again, if we all don't have access, we can also try emailing the authors whether they are willing to share the paper. Okay, I think these were all questions that that you had sent. Are there any other remaining or open questions or any new questions that came up in today's discussion? Anything specific that Till could help us with? Okay, it seems like...
Great, yeah, thank you for the excellent session, Janina and team.
Yeah, thank you for joining. It was very helpful to have you. And yeah, as I mentioned in the beginning, I was initially planning on talking about effect sizes and effect size calculations and meta-analyses next seminar, but this is more further ahead in the process. So I really like Till's suggestion to discuss your data extraction forms. So I would send out a reminder email that each of you prepares an example for your own review, and then we can discuss them amongst each other in the next session. Great, if there are no more questions, I think we are through for today. And yeah, if anything is unclear, you can email me or yeah. Great, thanks to everyone and have a nice evening. And then the next seminar is in 2 weeks. Great, goodbye everyone.
Great.